Okay, thank you. So I'm Susanna Sultan, a sixth-year medical student at Dhaka University, and our topic is patient-physician communication. So communication is an overlooked aspect of care in low-income countries despite its significance. So miscommunication often leads to misdiagnosis and poor treatment adherence. It also leads to wasted expenses on repeated visits to clinics, as well as complications. So we employed a descriptive qualitative study of two phases. So the first phase is an observation phase in order to identify the problems in communication, which built on the results of a clinical audit that we were conducting. And the second phase is an interviews phase in order to identify why those problems are happening. So the research paradigm that we employed is a constructivist research paradigm. So we started off with the observation phase. We were doing the observation phase hand in hand with the clinical audit. So the clinical audit basically assesses current practice against an international guideline, which leads me to the guideline that we used. So we we identified 15 recommendations of the NICE recommendations for adult patient experience, and we assessed 44 patient-physician interaction, like how doctors are adhering to those 15 assessment points, and we chose the gastroenterology outpatient clinic because it was the most representative of all other clinics, as well as in order to control for the topics that doctors would narrate, so that we could focus only on communication. So after calculating the adherence rates, we found certain aspects that doctors failed to meet the standards, and those related to getting acquainted with patients, such as asking about the patient name and doctors presenting or introducing their name and role. The second one was the personalization of care, so such as asking about the patient's how their condition affects their life and vice versa. And also indirect communication, such as eye contact and body language, in addition to showing empathy. Next, we followed up with interviews. The interview phase, we developed an interview guide based on literature search, as well as the gaps that we identified in the observation. We conducted 11 interviews with residents who have done a training period at the outpatient clinic. The interviews were transcribed and analyzed thematically. Thematic analysis revealed 4 main themes. So the first theme is residents' perceptions, and we found that there is a mismatch between doctors' knowledge about communication and their skills or how they apply their knowledge. And like when asking why this is happening, so we found that the second theme is the barriers to effective communication. And we found certain barriers related to physicians and patients, as well as other barriers. So physicians' barriers were mostly related to the lack of training, whereas patients' barriers were had to do with patients' unmet expectations or presuppositions about their conditions. Other barriers included time constraints and resource management, which was low, obviously, in low-income countries. The third theme, was the status quo of communication skills, which basically explored more in depth the observation results. And the fourth theme was recommendations to improving communication, and those were revolved around conducting consistent training, not just once a time training, as well as providing feedback and improving the environment or the work conditions where this communication is taking place. So to conclude, our study found that the application of communication standards is inconsistent and largely subjective. So doctors rely on self-experimentation and experiences that they're having instead of a certain approach or a guideline. And we also found that this is largely due to the lack of training and feedback, as well as the challenging work conditions. Our future plan is to continue the clinical audit that we've already started by implementing the change. And by that I mean teaching residents about the NICE guideline, about those recommendations, and the importance of applying them and how they can apply them. And we also hope that our methods can be applicable to other universities across Syria, so that we hope to collaborate with teams from different cities in order to repeat the audit and compare the results, so that we could hopefully reach a regional guideline that would improve the standard of care and standard of communication for all Syrian patients. Thank you for listening, and I'm happy to answer any questions you have.